Linh và cũng là một cái cơ sở rất là mạnh về kỹ thuật số. Xin giới thiệu tóm tắt thôi ạ. Cũng là bác sĩ, cũng là giảng viên và cũng là chủ tịch hội nha khoa kỹ thuật số Đài Loan. Và có cơ sở phòng khám và cũng là điều trị rất là nhiều vấn đề liên quan đến kỹ thuật số và bệnh viện. Và cái chủ đề tiếp theo lại hơi khác một chút, đấy là chủ đề về liên quan đến giải pháp cho ôn on xích. Thì tiếp theo xin có lẽ thời gian cũng có hạn và báo cáo viên nước ngoài đã phải chờ rất là nhiều thời gian rồi thì không có giới thiệu về nhiều. Thì rất tiếc là ở đây rất nhiều chuyên gia Glenn, chuyên gia Nha Trung nhưng mà cũng chưa có được cơ hội chia sẻ. Có lẽ cuối giờ thì có thể các quý đồng nghiệp thì các anh chị có thể ta chia sẻ thêm về vấn đề Nha Trung cũng như là về vấn đề Glenn ngày mai. Dear Dr. Michael Tsao, I am such intriguing you to do own genomic doctor. Now I would like to invite you to start your presentation.
Thank you. Okay, good morning. As you can see, I am not Dr. Michael Tsao. Michael is my boss, and usually he does our presentations in all implant surgery and things like that. I just finished a presentation in Hall A about aesthetic dentistry. So this is going to be my first time doing his presentation. So I'm going to be reading off some of the notes. I hope you don't mind. But I think it's going to be very interesting for a lot of you because this is completely new. And fortunately, even though Michael could not make it here, the thing that he wanted to talk about is the All Guide. And I am the inventor of All Guide. And so luckily I can do this presentation. So my background is also an engineer. So today I'm going to speak to you as the designer for implant surgery on 6 and on 4 from the standpoint of an engineer. So I'm currently studying a PhD right now at National Yangli University in Taiwan. And I'm also, in my spare time, I like to write programs because I have a special background in engineering. I like to write programs, I like to create videos, and also create 3D models. And I put these skills to the test by doing quite a bit of clinical research. When I first started joining the clinic, we were just starting to get into digital dentistry. So we had 6 chairs, so it's very small, we had a very small lab. And a lot of things either worked, or when they didn't work, we don't know why. If they did work, we don't know why. So in the early years, I spent a lot of my time doing research, trying to standardize our workflow. So for instance, we wanted to test what are the strengths and structural integrities of ceramics. So I designed this block here, so I can test no multiple thickness per block, so we can save a lot of material. And this eventually led us to discovering that it is possible to do ultra-thin veneers. This is the first ever ultra-thin veneer using can-can ceramics. And when we first did it, there were dentists and dental technicians from the UK, I remember, and also in Netherlands, in Europe, emailing us, telling us that we were lying and that this is a Photoshop. And so that was the first time we did it. In order to test the color theory, I was just speaking about this. I created a specimen holder using 3D printing to test different combinations of ceramic and resin to see their optimal response. And eventually we were able to quantify the colors in terms of major categories of ceramics, and that led to the sharp concept, which I just finished talking about 20 minutes ago. So I am a cosmetic dentist, and I specialize in one-visit interior aesthetic restorations. And I've also created a lot of other things over the years. Some are useful, like this 3D device that I created to test scanning, so that I can test consistently how long when I scan, is it better to scan more or less, or if is it better to repeat? or just scan it once. Some are useful, some are not so useful, so I also design a lot of things like this. So you might be wondering, what does all this have to do with implants? So I promise you that everything will come together at the very end. So one day I was sitting in the office, that is my office there, pointed over there, in our clinic, and my boss, Michael, so who is going to be here, and Michael comes in to my office, and he has a new idea. So we have every year, at the end of the year, in our clinic, in our training center, we have something called the Steroid Ultimate Experience. It is a big event, it's like a conference, and usually we do live patient demonstrations. So that year, Michael wanted to do a live patient all-on-6 surgery and restoration live patient demonstration. And because we only have very limited time, we wanted to do everything in 3 hours, finished. So the patient sits down and then gets up with the team, 3 hours. Okay? So at that time, I had no all-on-X experience. I had no experience. I've never put too much thought into all-on-X's, all-on-4s and all-on-6s. And I had very little interest in all-on-4s and all-on-6s. So the first thing that I needed to do was to find out, is it really difficult to do everything in 3 hours? I don't know. Is it difficult? And so after much research, if any of you here are doing all-on-4s and all-on-6s, you'll probably know it is very difficult to do these surgeries and restorations in 3 hours. So if you're not familiar with all-on-6 and all-on-4s, basically these treatments, they're divided into 2 parts. So we have a surgical part, and then we have a prosthetic part. Now, because each patient is completely edentulous, right? And there's very large surgical field covered in like swelling, soft tissues, and suture, clamps, a lot of bleeding. And so there's basically no reference for your prosthetic, right? So for an experienced clinician, if you're very experienced as an all-on-X surgeon, the surgery is the easy part. It's the prosthetic that is the hard part, right? So if you look on the right, there's basically no reference, nothing to fix your prosthetic to your surgical site. So how can we speed up this procedure? Well, one of the ways is to use a surgical guide, right? So if we want to speed up the entire process, then we need to be able to fabricate our denture before the surgery. This means we have to predict exactly where the implants are going to go. Okay? And this is what surgical guides are good at. But this is not enough. Surgical guides are not enough. And before I go any further to understand why it's not enough, I understand that not everybody here are surgeons, so I would like to backtrack a little bit and talk about and review a little bit about implant placement. So when we place an implant, we have considerations, right? So for mesial-distal distances, we have to consider natural teeth, distance to the natural teeth, distance to the other implants. For buccal distance, we have to consider occlusion, aesthetics, cortical plates, and for depth, of course, the anatomy and other important structures. This is well in theory, but it's actually very difficult to do if you're a new dentist. And the reason is because our views are oftentimes not the proper angle, right? So sometimes they're inverted, and they're not even upright sometimes. And once we make our incision, oftentimes our references are completely gone, right? The bone morphology may be different from what it looks like on the CT, and this can make the whole procedure much more experience-based, right? And that's the other problem, because to get experience, we have to shadow other clinicians to see what they do. But implant dentistry sometimes is very difficult to observe, right? So this is my boss doing his implant surgery, and you can't see anything, right? So when I try to learn, it's very difficult. So this is why sometimes we can use surgical guides. So this is a very quick review of doing surgical guides. The way we do surgical guides is a little bit different from the traditional way, because I was just finishing talking about how we do completely digital veneers and crowns. And we also do completely digital surgical guides and implant dentistry as well. So in order to get a surgical guide, we do the proper scans, we match the scans to the CT, and we set the parameters up to do the milling, right? So these are parameters that we set to see how thick and how much of a distance between the surgical guide and the soft tissue we want. Once we set everything in the system, then we can set it to mill. So this is a milled surgical guide. We can finish this basically in one visit. So once we have the surgical guide, now we can do the surgery. So this is, I'm going through this very quickly because this is just review for the interior, right? So I'm sure a lot of you are probably more experienced in surgeries than I am. And this is why we use surgical guides. So the surgical guides are really good at certain situations like this. So this is my anterior implants. If I'm doing autogenous bone grafting, right, I would like my implants to be placed exactly where I want it to be. And because I'm also taking chunks of bone from certain areas, I don't want these implants to be moving around in different places. So I like them to be fixed in place, exactly where I want. So for precision removal of autogenous bone, it's very good with surgical guides. And this is an example. This is the same example taken to completion. But what about edentulous ridges, right? What about edentulous? So for surgical guides, you have to place them on some kind of hard tissue, right? Mostly teeth. You can do sometimes on soft tissue, but what if it's completely edentulous? So how do I get a guide to work? Well, at the time, when Michael first threw this idea at me, I had to do a little research, and I realized that, well, people were already doing this. This is not something new, right? So if I look at this research paper from 2019, this is a research paper doing a completely edentulous mandible, and they're restoring it using a surgical guide, and they're doing it completely flaplessly, okay? So let's take a look at how they designed their surgical guide. So this surgical guide, because when you place the guide on top of the soft tissue, it moves around, right? And we don't want that to happen. And so the way they did it was they used bone screws, right, or bone pins, and they pinned the surgical guide to the soft tissue. Makes sense, right? Makes logical sense. So here's the final product, okay? And then after they did the implant surgery, right, they can take their denture. The way they did their denture was they had to make a duplicate denture, right, so that they can maintain the vertical dimension. And then they take the duplicate denture, and then they use that as a guide to arrange for the complete denture, okay? So this paper was helpful, but it's not exactly what I want, right? And there are two problems. One is that they did this completely flaplessly, right? And for all on exit surgery, you can do it flaplessly, but what if you can't, right? So this only works if it's flapless. And because it's an overdenture, so it's much easier, right? Overdentures, your implants don't have to be in the exact same position. You can kind of move around a little bit to make it work. But we can make use of, so you'll see in my design, we made use of some of the ideas in here. So in order to figure out, is this accurate, right? So we can take a look at some reviews, and this is one slide just to give you an idea how accurate these surgical guides are. This is review for edentulous ridges. So these are all bone pin surgical guides. And you can see the numbers there. Basically, here's what it looks like. For implants, we have deviations about 1.3 and 1.3 on the horizontal, 1.5 on the apical, 0.2 and 0.5 on the implant neck and on the implant apical region, and an angulation deviation of 3.3. So it's very accurate. I was actually pretty surprised that this is accurate. But why does it still have sources of error, right? So I wanted to figure it out. And there are three basically sources of error for edentulous surgical guides. It's the quality of the radiograph, is the surgical technique and the guide material, which I'm going to focus on in the very end. So, the quality of the radiograph can basically affect how your surgical guide is going to fit, right? So you can see here that these two are the same patient, but if you change the parameters around, sometimes you can get better quality radiograph. So that's number one. Number two is that if you're doing flapless, if you're doing open flap, if you're doing grafting, if you're doing a lot of different things, they can change the accuracy of your surgical guide, because when you do flapless, you have all the references maintained. But if you are doing open flap and if you're doing grafting as well, basically you've lost all reference, right? So the surgical technique is one of the sources of error. But most importantly is the guide material. So if you look at these guide materials, and if you look at other people, how they did their surgical guides, you'll notice that they're all resin-based. So they're all resin-based material because of the ease of application, right? The problem with resin-based material is that they're not very strong. And because they're not very strong, they have to be really thick. The volume has to be a lot to make up for the lack of strength, right? And this volume then obscures your view as a surgeon, right? Because you're seeing a lot of things in the back and you can't really see where you're going. So at the time, I wanted to do this kind of design, but I didn't want to use resin. So luckily, there is another option, which is using cobalt chromium. And you can 3D print this. So we can design something and then 3D print it so that it can be strong and it can be made very thin. And it can also be used as a support structure for denture. So here is a summary of challenges that we're now going to solve. So number one is we need a reliable surgical guide. Number two is we need to somehow reference the original vertical dimension. And number three is we need to find a way to quickly fabricate a denture that can be delivered very quickly. So this is the challenge that Michael gave me. This is a few years ago. He wants to do all these things in 3 hours. So as an engineer, I started to design, and after about 2 months or so, this is our first version. So these are my drawings, and I'm also a clinician, I'm also a dentist, so sometimes it takes me a long time to do engineering work because that's not my main job. But basically, our design is called the All Guide, and the All Guide has 3 major steps, okay? On the left, we have something to establish a vertical dimension. In the middle, we have an insertion of our devices into the bone. And at the very end, we have a framework and a denture that can be placed onto this insertion. Okay? So let me show you how this is possible in 3 hours. So to establish the vertical dimension, we first need a scanner that can scan the denture's ridges. Okay? So we were using 3Shape before, and it works fine, but soon after the prime scan came out, and then so we started using prime scan, which is a much faster way to scan the denture's ridge. So once we finish scanning the denture's ridge, so then we have to figure out a way to allow the prime scan to stitch together the denture's ridge and maybe the original denture, right? So if we're using the original denture as a vertical dimension, or if you're using a jig, or if you're using some kind of a device to maintain vertical dimension, we have to be able to match our scan to that, right? So top right shows the old denture that we scanned. So we scanned it in a completely 360 degrees. So it's not just the outside, but also the dentures, the tissue side. And on the bottom right is the match, right? You can see that the prime scan was able to match completely these 2 scans. Now, once we have the vertical dimension established, now we can use it to create a duplicate denture. So remember that paper that we were talking about using duplicate denture, right? So I stole that idea, and then now I'm going to design this duplicate denture. But I need this duplicate denture not just to maintain vertical dimension, but I want it to actually lock into the device that will go into the bone. So what do I mean? Once I place the duplicate denture, which I call carrier, because it carries the dock into the mouth, once I place that onto the patient's mouth, onto the denture's ridge, then I can lock the dock onto the carrier, and I can put the bone pins in. Okay? So once the bone pins are connected, I don't have a, can I draw here? Okay. So this will lock with this, and these are the bone pins. So these three are the bone pins. The bone screws will go in there. So once the bone pins are connected, right, the dock is now fixed inside the patient's mouth and it's fixed to the mandible bone, right? So it can't be moved. Now it's a reliable reference for any module that we place on top. We can place different kinds of modules. We can place the carrier back to check to see if the vertical dimension is okay, or we can place a guide like this. So you can see that is our surgical guide. And here's this quick video that I made to show you how everything goes together. Okay? So everything is locked together. And remember the dock is also locked to the bone already, so everything will be fixed together. Okay? So here you can see the actual surgical photo. So on the left is our design, on the right is the actual guide with the dock at the bottom pinned to the bone. So once we have the guide in place, the actual implants are already placed in this photo, right? You can see the implants and the abutments coming out of the guide. And once we have this guide and all the implants placed, we can remove the guide, right? Remember that the dock is already fixed, so we don't have to worry about that. We can remove the guide and then place our framework. So this framework on the left here, this will go inside our denture. Because for traditional all-on-6 and all-on-4 dentures, usually it's completely made of resin. And that can be good for maybe a short-term temporary, but a lot of the time it will break, right? Because there's a lot of mastication force on our dentures. So my boss wanted to get this denture, but he wanted me to design a denture that he says will be a long-term temporary, like a really long-term temporary. If the patient wants to wear this for a year, maybe 2 years, they can. And so I designed this framework to go inside this denture, and this is what it looks like, right? So the framework will actually lock inside a prefabricated denture. The denture will go on top, and everything will lock together. And it is, because it's designed to fit in there, so the fit is actually quite snug, and we just fill all the empty spaces with special resin. There's a special type of resin that we use to fill it in, right? So there are still weak points because of the attachment and the bonding between the framework and the denture, but it is a very snug fit. And here is a view on the bottom, and because this was one of my first designs, so I don't know if you can tell, there is a Love Taiwan somewhere in the framework. And the reason I did that is because I ran some finite element analysis on this framework, and I realized that actually, it really doesn't matter what shape the framework is, as long as you have supporting structures, so I just designed something. I also wrote other things in my other frameworks, but in this case, this was one of the first, so I wrote Taiwan with Love. So, this is the final picture, right? So this is after the framework. The dock has been placed. The dock has been pinned. The implants have been placed. And then the framework is also placed in there. And now we have the denture on top. So this denture is literally floating in the air. This is not possible if you're doing a traditional all-on-6 or all-on-4 because there's a lot of soft tissue on the bottom. So this denture is literally supported in the air by the framework. And the height was already established at the very beginning with the carrier. Okay? So, this is the before, and this is the final. So that is the one with the framework in there. All performed within 3 hours. Actually, it wouldn't have taken 3 hours if Michael would stop talking because he would always do surgery, and because it was a live demonstration, he had to talk and do surgery and talk and do surgery. So I think if he were to do it very quickly, it probably could have been done within 2 hours. So, as an engineer, I would like to see my design, if it works. If we can successfully finish it, it doesn't mean that it works, right? We have to try to check to see how accurate it was. So this is the actual CT, right? The CT of the finished product. I've extracted it, made it into an STL, and then compared it to my original design. And so you can see that there is small deviations, right? And a lot of this deviation comes from the fact that if any of you are doing a lot of surgery, you'll know that we can never trust our CTs, right? So the CTs, sometimes you have bone densities that it looks fine in the CT, but it actually is not fine. And so a lot of times the surgeon has to make a snap call, a snap decision, to change the direction depending on the bone density. And so in certain cases, this is happening. So there will be small discrepancies. So if we compare between the actual end result versus the design that I had, we can actually find out the deviations for them. And so these are the deviations, and if you take the average value, that is the average value. So remember the deviations we talked about before, right? 1.5, about 1.5-ish. So it's pretty close. It's pretty close. Not too bad. And here is, because Michael's not here, and I told him that I would put a picture of him on top. So here is him actually trying it out. So don't worry, we didn't actually just try the patient on the first go. We tried it on models first, right? We tried it many, many times on the model to make sure that it works. Beside him are implant surgeon and our prosthetic specialist. So they're both helping him to see if some things will go wrong. And this was a live demonstration. So actually, we did this live patient on the left, and there's all these streaming devices, and then it's streamed to this audience, much like this, right? And so people were watching this live when they're doing it. This picture is from the next day. This is why you can see the finished product. But basically, it was live streamed over there, all within 3 hours. Okay, so that was that. But we weren't really satisfied, right? Because even though it worked, we were kind of lucky in certain respects, because not all on 6 and 4 surgeries are the same. Sometimes you have a lot of bone that you have to reduce. Sometimes you have too little bone, you have to do bone grafting. And so Michael wanted to design a new design. And so then we went on to design our second version. So this is actually our third version, but for today, because I want to shorten this speed, we'll just say this is our second version. So this is a different version, completely customized for the patient. Okay? And the reason why we have now a 3D framework. So the old framework was a flat surface. And I didn't really like it because as an engineer, you know that anything that is flat has no strength in the vertical dimension. Right? This is why when we build things, when we build buildings, we build them in like I-beams, right? We have vertical, horizontal, but in the horizontal beams, we also have vertical components. So I wanted to build vertical components onto our framework. And so here is the carrier with the dock, and on the right, you can see that the dock is now placed in the patient's mouth with the guide, right? So this is the guide, implant guide with the carrier. And for this patient, because we have a lot of bone loss, right? So we have a lot of vertical height to work with. This is also why we can make a 3D framework, is because if the patient doesn't have enough space, we can't make it 3D. But because we can make it 3D, and because we have a lot of space, we decided to do this without opening the flaps. So this is a flapless surgery. And this is the tissue punch to remove the tissue with placing the abutment. Here it is with the abutment placed. Okay? Now, because when we're doing these kind of guides, it's never perfect, right? Everything will have a little bit of discrepancy. And so this is why I've made these frameworks to have these holes slightly bigger, just slightly bigger than the actual implant size. So that in case, like, if an implant needs to be deviated from a certain area, it will still fit within the framework. Okay? And so as you can see, these are the implants placed with the abutments, and all the abutments are actually inside the framework that we have. So for this case, instead of using the special resin that I talked about, it wasn't actually very accurate to use special resin because you're basically just slobbering all over the framework, which is not very accurate, but also when you're doing it in surgery, because remember you're doing this inside the patient's mouth, right? And so there's a lot of bleeding. You want to try to use as little bonding, as little resin as possible inside the patient's mouth. And so for this case, I designed a lid, a cap, on top, so that now, once we place the framework in, we have a lid, a cap that can go on top, and so that will reduce the amount of bonding that we need, so we can place everything inside, like this. So everything will fit together, and hopefully be stronger. So this is with everything put in place. You can see that on the right we have the final product once all the implants are placed. So on the day of surgery, this is the actual final product, right? So for those of you wondering, there are actually four metal positions here, here, and here, and here. These were the frameworks that were connecting to the dock, right? So we had to cut them off. And remember, this is a temporary, so yeah, it doesn't look very good, but it's temporary. If you really care, some patients, when we did this, because we've done about, since then, I think we've done about 60, 65 cases. Some patients really care about these metal parts coming out, so you can just kind of grind them away and put resin on top, and then they'll be good as new. So this is the final product. Okay. And you can see here is with the framework on top, and here is the final product inside the patient's mouth. Okay? Okay. Are we satisfied yet? No, of course not. So Michael, after doing this, he said that, yeah, this is good, but what if I want to do a final restoration? Maybe I don't want a temporary restoration. Is it possible to do a final restoration? Now at the time, I didn't think it was possible, and I still don't think it's really a final restoration, but we decided to try this method, now using a completely different material. We're going to use zirconia. Okay? So it's possible to do this with zirconia. So here's our next case. Okay? And here is the panel graph. And you can see that we're now going to treat the bottom teeth. Okay? So we're going to remove all the bottom teeth and then replace them with a all-on-6 thing. I think it was an all-on-6, I can't remember now. So because the patient already has teeth, this time we don't actually need a carrier, right? Because remember, the carrier is only used if you have edentulous ridges and you have to have a vertical dimension. But now, we don't actually have to use the carrier. We can just use the original vertical dimension, right? So I designed this special carrier so that I can place on top of the patient tube, and then that's how we reference the dog. So we can place the dog inside. And once the dog is drilled with the bone screws into the patient's mandible, we can remove the carrier, and now we have a fixed reference for our mandible. So we can remove all the teeth, we can remove everything, and we can still know exactly where everything is, right? So this is after all the teeth extraction. I'm sorry if any of you don't like. I'm not a surgeon, so I really don't like watching these photos. So usually when I finish my design and my boss is doing these surgeries, I'm just standing really far away, looking at our television prompters to see what he's doing. So usually when I do surgery, I would do like anterior implants, so they're quite easy, but not these ones. So This is with the guide on top. So once we have the dock in place, we can place the cerebral guide on top to place the implant. So this time, remember that we're going to use zirconia now. Okay, so this is zirconia denture. And the thing with zirconia is that it's actually very difficult to fire when you have such a large structure. So we had to, the framework had to be specially designed so that the geometries don't break easily. And so these supporting structures, these passive fit divergent groove designs, they're kind of for the framework, but they're not really. They're actually for the firing of zirconia, because zirconia firing cracks very easily when they have such a long span due to the internal stresses during the firing. And so these are specially designed cuts and grooves for the zirconia firing. Finally, this is the final product. And this is the follow-up photo of this design. So the thing with all on sixes is that you can unscrew them, right, to clean them. And so this is what my boss is doing. And here is the final result. So you can tell that this is zirconia because everything is just completely radio opaque. Now for the top teeth, the patient wants to continue doing treatments for the top. That's not the topic for today, but basically we just did regular grafting and finish the top, which is standard implants and bone grafting. Okay? So are we satisfied yet? No, of course not. So, this all started when my boss wanted to do Michael wanted to do 3 hours all on 6 surgery and restoration. Right? And then so over the years, we made different modifications to designs to optimize the design. So about 2 years ago, this is when COVID started to hit. Our clinic started doing navigation, so implant navigation. So I don't know how popular implant navigation is in Vietnam, but in Taiwan, it's starting to get pretty popular. A lot of clinics are starting to use it. So when I was doing implant navigation, I thought, what if I could just use this navigation for the all-on-6 treatment? Because if I do that, then actually I don't have to design the guide. I have one less thing to design, which is great, right? Because that means I can spend more time doing the actual restoration. So this is our all guide or guideless design. So this is the patient, and we're going to remove that remaining tooth on the bottom. And then you've seen all this before, so I'm going to go through quickly. So we'll place the dog on there. So for this one, because this is our first time, I didn't want you to go straight into a guideless navigation design. I wanted to have a backup plan, so I actually designed a guide as well, just in case things didn't work. But we actually did use the guide because we started to use navigation. So for this case, I think Michael, so that thing on the bottom right, that is a reference for the navigation. So we're not going to go through that today, but basically it has an imaging system to continuously take videos of that device to know where your handpiece is. So for this case, Michael did the implant placement with the navigation, but also with the guide. So they're all working together to see if they fit the same. And eventually, after one implant placement, everything was good, so he removed the guide, and he did the rest of the implants using a guided system. Okay? And so this is the final product after placing all the implants on there. So you can see this is our framework. And this is after with the denture placed on top, and also with the bonding to the framework. And this is our first ever navigated all guide for all on sixes. So ever since then, we've been doing navigated guides. And I love doing navigated guides because every time we have a patient like this, I taught this design to our technician. but they still ask me for help sometimes. So when we do navigation, it means we have one less thing to design, right? So it saves a lot of time when we do navigation. Plus, for a lot of surgeons, if you are surgeons here, you'll know that during implant surgery, we have to make a lot of adjustments, right? Like I said, due to the bone condition. And so with the guide, sometimes it feels very limited because you have to place that implant in that position. But now, with the navigation, there's a lot more leeway for the surgeon. Okay? So, this is my last case that I wanted to show, and this is the all guide that Michael and I would like to present to you today. Now, I know that I may have missed a few things, so if you have any questions, or if you would like to learn more, feel free to join this Facebook group that we literally just created last week. So this is our Facebook group. You can join, it's for free. But because we just started, you have to wait a little bit before we add more content. Basically, there will be case studies, discussions on clinical applications, and other things. There will be me, also our staff members, and other dentists, and of course Michael in the group to give you a little bit more information, maybe answer some questions you have. Okay, and so this is a very quick rundown of the all guide and the new surgical technique and the design that we have. So my name is Dr. Shen, and thank you for inviting me to speak today. That is all.